Okay, so questions on what we discussed? Yes. How does the system bypass the AV node if the AV node is not working? SA node at 60 to 100 that would send out the signal, but instead of the AV node being the receiving signal, you would receive it at the, they may not all receive it. So if you were to look at that on a EKG, vice versa, it would kind of depend on where the signal was being picked up at. Because if the plan with all these little fibers and stuff that come around, so maybe it does make the jump there. This side conducts really well, but it might not make the jump here. So this side rate would still be higher at that 60 to 100. Typically, what we're saying though is that like if the SA node does slower rate, and then if the AV node quits working, then the Purkinje fibers will pick up at a slower rate. That's more typical of what happens. It's still electricity. So like you've seen lightning, right? The whole time? No, it's transmitting through the air, through the electrical particle hitting it. And it's the same thing in the heart. It's not nearly as strong and it's not nearly as large of a distance getting that signal. So the signal is initiated in the SA node and it sends it out, and those other were sent. But sometimes if one of them isn't working, another place tries to compensate. The signal is still being sent, and that electrical charge is still going to make it. But just like distance, maybe it just kind of goes out across the sky and you see the light, but you don't hear that boom. Same kind of thing. Some movement, but you might not get that nice contraction of the heart like you're supposed to. Does that make sense? Okay. Questions on that? All right, so now we're talking about the regulation of the heart. So our heart out, but there's things in our life that occur, like y'all just took a test this morning, right? So what was your heart rate going up, right? Because you're accessing that acceleratory center or that speed up center. So signals, the medulla, right, is sending out this signal that says, hey, I'm regulating your heart. You need to run. Well, what do you have to run? Faster heart rate, extra oxygen, more blood volume. You got to get it, or a pressure sensor like from the vagus nerve, something that has slowed everything down, right? So it kind of depends on what we're using. Norepinephrine, right? Sympathetic is norepi, and then you have the inhibitory center or the parasympathetic system, and that's response, like we talked about, that baroreceptor, and then you also have chemoreceptors affected by to speed up the heart rate, and parasympathetic is going to slow the heart rate down. So some of the hormones of the heart rate increases. It's also going to increase the force at which the muscles contract. When that cardiac output, it's going to increase, right? Because heart rate times stroke volume, which means that it's going to be pushing out a little bit more blood. Our heart rate's gone up, so our cardiac output's gone up. Because we've got more force, but in addition to that, what did our blood vessels do? Did they dye blood to come in? So you're maybe not having that resistance, but you're still getting that volume moving through. Aldosterone's coming from the adrenal cortex. That's going to regulate our sodium and potassium. Why does sodium and potassium? Okay, so what's causing that arrhythmia or that contractility? Goes back to what Patrick, does potassium conduct electricity? Yes, if we don't have the adequate amount of sodium and potassium to electricity conducts. So let's say if we're looking at my heart right here, I'm going to face this way. It's not supposed to travel to here. And it's supposed to take 1 second for that travel distance, right? But now I've got from too much potassium, too much sodium, whatever. Is it going to move faster? Yeah, because the conductive kalemic, I don't have enough. Can the electricity transfer as fast if it doesn't have all those under 2 seconds? So that's the reason it's so important to keep those electrolytes in balance. Muscle can't work as good if the electricity can't move through the heart the way it needs to, because we don't have the electrical impulse control. That what's atrial? What is that? Heart where? In the atrium. How big is the atrium? Much, right? But say I've got fluid volume overload, right? I've got my kidneys aren't. What does my heart have to do to accommodate that? Stretch. It's got to pump harder. It's got to stretch a muscle. Think about it right now. If y'all were to bend over and touch your toes, what would you feel in the back of your legs? Some tingly sensation if you haven't run in a while and your legs get tingly. You're releasing proteins, right? Your muscles are being used, and in response, it's going to release a protein or a peptide. The atrium is that stretch, that hormone release occurs, and it says, wait a minute, I've got. So then it sends a signal that says, you got to get rid of fluid. You got too much fluid. You got to get rid of some. You're going to alter your aldosterone, which is going to increase that excretion of fluid, right? So go back to our fluid electrocrine system. That aldosterone is going to come from that renin, aldosterone, angiotensin, that we've got too much fluid on board. It's going to send, the renin is going to send a signal there for the aldosterone. It's going to convert, and we're going to get water going to follow sodium. We're going to quit absorbing the sodium and send it out. Do y'all remember that? All right, so that's what's happened. That ANP is to a stretch of the atria that says, I've got too much on board. Let me sodium, because water follows salt, and we're going to excrete that from our body and decrease some of that blood volume. All right, so the blood vessels themselves. We've already talked a little bit about arteries, and we talked about veins. We've got arteries. It's oxygenated blood. but not every single time because we still got the lumps there. The heart. Sorry, let me not choke. And then the capillaries, how thin or thick are capillaries? Tiny little superficial vessels that are allowing the exchange of nutrients and oxygen to occur as easily. No. So capillaries are going to be nice and thin to allow the exchange of oxygen. Take that, send it back to the heart, let it get reoxygenated, let the body use what it needs, and return from the heart, right? What does an artery look like? Is it floppy and thin? Is it nice and thick? The blood flow is stronger, absolutely. So if something's pumping at the force of the heart, right? So they're going to be thicker, stronger. And then the veins, are they going to be as thick? To put in an IV, sometimes you feel a little resistance or a little pop when that IV catheter goes in, but not so much because the veins are typically thinner or harder or thicker. But as nice, young, healthy people like all of us are, we still have pretty reasonable veins. All right, so here we're looking at, and we can see how much thicker that layer is that's going to support. And then we can see at the vein at the bottom where it's a little bit thinner, is a little bit more pliable. What's one thing you also notice in the valve? That valve is what is absolutely essential to ensuring good blood flow. So we see very pulling of blood inside that vessel. A lot of times that valve isn't working. It's not stands in that area. So that's what you're seeing on the outside. All right, so that takes us to a little bit about the things, but we're going to get into it in a little bit more detail. So what is the actual blood pressure? The blood against the blood vessel walls. Okay, so we're actually measuring the millimeters of mercury of pressure. So what all do you think would directly impact that? Yeah, sure. What do you think is actually going to direct? Okay, smoking. Why? But why? Okay, so how does that alter the pressure? Constricts the vessel, so you've got a narrower space for the blood to go through. What does it do to the? So what else? What else is going to affect our blood pressure? We know the stiffened arteries impact our vessels. It's clogging them with what? Little fat deposits, right? They're functional, but it's got this big clump in it. So there's less room for the blood flow to go through, which is going to in turn create more resistance. If the heart's beating too fast, or maybe if the ejection fraction is altered, the volume coming out, dehydration, low, overload, maybe high, and somewhere in between, because the vessels are fine, right? Maybe they're nice and pliable and moving, but if we're trying to fit twice the volume through, they're trying to fit in the narrowed space. So those are some of the components that do that. So we've got this nerve is going to help tell the vessels if they need to constrict or if they need to dilate, and we're fine. And then we stand up real quick, and what do we feel? Maybe lightheaded, dizzy, static hypotension. And a lot of times that's occurring maybe because our movement was a little bit faster, like it takes just a second for our body to sense that change in those nerves, that they change, then send a signal to our brain that says, oh, constrict really quick. And then our brain has to send a. So your afferent neurons are doing what? Sending it to it, and our brain sends constrict your vessels. But if you've been laying down for 30 minutes and then you stand, it may takes you to stand. So you get that temporary dizziness, but then your vessels immediately constrict and you return to feeling just fine within a couple. Slow down. So are their signal responses slower? Are they more likely to have recurrent episodes cover faster or slower? Slower. So there's your risk for falls. That's one of your cardio. We talked about renin and the angiotensin and converting it. And so we're looking at the blood fluid or releasing a fluid. We're not going to spend a ton of time on this. You guys covered this thoroughly in renal fluid electrolytes, and to indicate to you a little bit about its significance if we talked about it in 3 or 4 chapters. We're not going to spend a ton of time on this. Just make sure that you decrease your volume. Okay. All right. So pathways of circulation. We've got the pulmonary pathway, systemic pathway, right? Yes, it's coming out of the right ventricle, going where? How? What takes it to the lungs? A minute ago. It's coming out because it's coming away from the heart. It's coming out by the pulmonary artery, going to the lungs, and go back into the pulmonary vein, which is going to return it to where in the heart? The left atrium. And circulation is kind of all its own. It's leaving that right ventricle and returning to systemic circulation. What is the systemic circulation? Through the entire body. Absolutely. That's the blood that's leaving that left in our toes, exchanging oxygen and gas and nutrients at that capillary level, moving back in and superior vena cava. There is one exception to the rule. That is the hepatic portal. That portal of circulation in detail when we go into some of that liver stuff and GI stuff. I'm not going to give you a big deal on it today. Stuff kind of has to go through the filter before it gets out the way out to the body. Otherwise, what's the point in having the film? Where it filters that process and it makes its own little circulatory system. We've told you about that pressure as the blood can back up in there. That's part of that hepatic portal of circulation issue. That is the one exception to the rule, really, when we talk about that pulmonary or systemic circulatory process. All right, so conduction cells, those electrical cells or electrical impulses are being conducted more slowly. So what is saying slow, but what happens to the heart rhythm when the electrical conduction is altered. Either way, it's an arrhythmia or dysrhythmia. It's something is out of the normal rhythm for the heart. Atherosclerosis, what in the world is that? Fats in there. So you talked to me a second ago about cholesterol. Well, that's when those fat and cholesterol deposits build up inside those vessels. And our body tries to prevent that by putting what inside of our vessels? Endothelium, inside the vessels. That's that skating rink surface that allows those lipids to slide on past. That endothelium can't always resist the volume of fats we take in or the way our body processes them. And we think blood pressure increases. Why? Well, we just said that we've got atherosclerosis. We just said that our conductivity is different. Arteries are hard or soft as we age. They get harder. So the vessel's harder. It's should we have higher blood pressure, right? Because we've got all these forces of resistance working against it. Why? What did we just say about the conduction cells? They're slower. So we're probably heart rate is set at a baseline to kind of maintain our metabolism. So those of us who are runners, we're going to have got this nice metabolism. For some of us who, like me, like to eat cookies and have a little extra weight, my body and my heart increased from what it used to be when I was 20 years old and still ran all the time. So you got to think about that from distance track runner or soccer player coming in and they got a heart rate of 40. Do we panic? Do we ask them, how do you feel? Yes, part of their normal. But as the general aging person progresses, the heart rate's going to slow down and everything starts to slow. And then these vein valves. So what do we say about these valves? They're doing like, can something do that before it starts to get worn out? Clearly a lot, because they last till we're 80 something and they do it. Return decreases. So what do we see? If the blood return to the heart, what do you expect to see? The change in color of their legs, sure. Maybe some space. Is that leg going to be hot or cool? It's going to be cool. Arterial, but if that's venous blood that's not getting out, that's going to be cooler because hot, fresh changes that area will be warm. But if it's venous and we're just not able to get, some of that out, you're initially going to have, and then it can change into cool over time because it's never going there and it's stasis. Things lead to, oh, look at there. I love when I say something and it matches. Venous stasis alteration. The blood went on your wound care day, saw patients who had venous stasis ulcers. They didn't have adequate blood return. There was decreasing old and clotted and nasty. There was poor blood flow to the area. The tissue started to break down and it left this hole in their leg. And it's giving us fatigue. The blood pressure increases can do a couple of things. Make a heart work harder. Put you at high risk for heart attack, stroke, all failure. It can only compensate for so long before it gives out. That atherosclerosis or the narrowing of those arteries and clogging up less space. And the endothelium makes it smooth. It's fat, nice and smooth. No, what is it out there in that circulatory system? What does it do? Let me just snag this platelet. Let me just snag this little red blood cell element. And then you have decreased blood flow to the heart and other organs because if the heart can only work so hard, so we're going to have those patients who have those cool fingers and stuff because the blood's just not making it to their fingertips. What's their oxygen saturation going to be? As much of that oxygenated blood to the extremity. If we put it somewhere warm or pre-warm the hand, do we need blood for our liver and our kidneys and everything else to work properly? Absolutely. The function of all those other organs going to be the same. No, it's going to decrease as well. And so I know, especially in clinical, about like how this function happens and this cascading effect, and you're able to see how every one of these things are impacted by this physical component. So, cirrhosis that we just talked about and the arteriosclerosis, the blood pressures increase and the valves are less functional, so it's not necessarily working as efficiently. It might be working just as hard. The heart may be beating just as hard as are common. So, heart disease or the development of cardiovascular disease is the number one cause of death in the U.S. Heart disease. We do a lot of campaigning in the month of October, right? Everybody wears pink. We do a ton of, we shouldn't campaign for breast cancer awareness and alterations in that. But what I am saying is that maybe we should go red disease and we don't put that much focus. Partly because it's so much impacted by lifestyle things. So smoking, exercise, dietary fat reduction, weight. I'll assure you that I struggle with several of these because I don't want to exercise, which helps make me be overweight. So it's kind of a cascading effect here as well. So it's important to make sure the risk. And then as nurses, we all should be trying to make an effort to maintain each a little bit. It's hard to go in there and listen to somebody tell me you shouldn't smoke if they're smoking a cigarette. We should make a little bit of an effort to at least practice what we preach by living some of those healthier lifestyle options. So there you can talk about Go Red, and red dress is linked with that visualization. So if you're looking for any of those additional links, there's your access those as you wish. But that being said, we are going to talk a little bit about our cardiovascular things. What are some of those things that we're going to do? Sam, I don't know if I can actually hear them. What medicines are you taking? How do you feel? Do you have to prop yourself up on pillows at night? Sleep a day. Who had the patient with a terrible heart failure that was sleeping like 16 hours a day or something? They slept like 16 hours a day, and it was like a catch-22. You want to make them exercise and do things to help improve. Preventative care is so important, is working with these patients early on, because once they get to a certain point, sometimes it's very difficult. That's going to be better. So what else in our health history matters? Allergies, genetics. Family history of heart, weight gain, smoking, absolutely. So as you're going through, thinking about what you want to ask, any dizziness, right? Because what's the last things to get blood? Fingers, nose, and toes, right? Those little bitty extremities. But the important aspect of cardiovascular assessment is checking someone's toes. Do they have their appropriate cap refill? Is that a cardio assessment refill? Is a cardiac portion of your assessment, just like your peripheral pulses are. So remember when we went into this little room over here and we all yes, pulses in the feet, pulses in the wrists, and cap refill in the fingers and toes. Why? That's telling us blood. So all of those are important things that you're looking at. So part of that physical assessment, they're looking at those toes. What else? Auscultate the heart. Yeah, absolutely. What should we hear? Love dub. S1 times? Yes. Do we know every extra sound? Absolutely not. Me either. I learn everything that I can, but when I don't recognize something, what's the most normal, and find that person who does have the expertise in that area who can identify that sound for you. And there's your learning opportunity is, but you can identify that it is abnormal and contact the appropriate personnel. So we've listened to them. We've heard S1 sound. That's the valves closing, right? So that S1, which valves is that? Which is the tricuspid and the mitral valve. And then that S2, that second be the pulmonic and aortic, right, as it's leaving. So that's what we're hearing. Then we're listening for those other sounds, maybe where the blood's backing up and you get that, or you're listening for an extra sound where it meets because the valves are not closing together. Maybe one of them isn't functioning as well. So we're listening for all those things. Feeling their fingers for cap refill. We've assessed their peripheral pulses. Vital signs, which vital signs? And heart rate. And if you want to consider SpO2, I'll take that too, because even though that's an oxygen, it is also dependent on the heart to get the blood to that extremity to assess it. What else? What did you see? What did you tell us you would see in a patient who had impaired venous return from their extremities? Edema. Those are all components of that physical cardiac assessment. What about the neck? Pulse just bounding while we're sitting here. JVD. I've got a video we're going to watch about JVD that's a little bit easier to see than trying. You'd be able to see my jugular vein. No, right? Because it's working with what? Gravity, right? But here, may you see some JVD at that point? Possibly, because he's trying to get to go down where it should be, but it may not work because I've got my legs up and I'm laying flat. Maybe in a but someone whose heart's struggling, that JVD assessment you're going to see a little bit sooner. So the way we're going to see, do we even see anything? Then we're going to start lowering them down. I don't know if you've paid attention to this, but on every bed, glass window with a little metal sphere in it. That little metal sphere, wherever it lands, it shows you that you're lowering them down, you're watching their neck, you're watching, and all of a sudden you start to see this right here in the neck, right? And you stop. And you look at that little is laying down when you see that. That's how we're going to assess that JVD. Some people you may, between that 45 and 0 degrees, not terribly worried because that's okay. But if we're seeing it, all right, and like I said, I got a video for you. We'll watch on that in a minute, and it's on Moodle, so you can watch it out. This is part of a cardiac assessment. This might be a little bit of a trick because you're probably going to tell me it's part of your respiratory assessment. Breast fluid buildup, right? Because we just talked about the fact the heart's working to circulate all of this stuff, but it can't hold up so far before it backs up. And then it backs up again, and it backs up again. Next thing you know, we've got all this fluid airspace, so it can hold that fluid. Our legs are already filled. It starts to settle in there. What do we hear when we listen? What we're hearing when we're listening for that fluid. So that's a common sound that we're hearing when we've got that fluid excess. The heart can't move it around as good as it needs. Sure. Are we going to have more of a cough when we have wet lungs? Yes. Why? Because of those alveoli force that fluid out back into that vascular space so that it can go around and be that. What is our intervention for a patient who we do hear those crackles on? Turn cough, pursed lip breathing, or that slowed huff breathing. Absolutely. We want to do what we can to think of respiratory assessment as those auscultation of the breath sounds. That's also an important part of your cardiac assessment. Because secretions and bacterial junk growing, that's one thing. But if that fluid sound is coming from fluid, much as it is a cardiovascular finding. And that's why knowing these together is so important. That's why I want you guys to really make sure you got that AM. Am I missing anything? Did I miss anything I want you to know in there? I don't think so. If a patient breathes pillows at night, what's that called? Starts with an O. It's called orthopnea. That they have difficulty breathing when laying flat. And however many pillows you want. If somebody has to elevate to be able to breathe at night when they're sleeping, that's called an orthopnea process. Heart failure. Heart failure, you got that fluid retention that your body's not able to get. 348, it talks about subjective data collection. And that's some of the stuff that they ask you is like swelling in your legs and your feet. What's your diet? Do you experience shortness of breath here and there when? Those kind of would also would be to do with the laying down flat to sleep and stuff. All right, so that physical exam, we talked about that. Let's talk a little bit more about that orthostatic blood pressure. We know why it's caused, right? And we know what the signs and symptoms are. Assessing it. How do we do that? How do we assess someone for orthostatic hypotension? Vital signs. We're going to have the patient get vital signs from them while they're sitting, while they're standing, and while 49. Box 21.2 talks to you a little bit about orthostatic hypotension assessment. What position we're going to do, 3 minutes, that's right. And then I would also refresh habit, right? We go into the hospital, the patient's laying there, we put their blood pressure cuff on, we hit start on the machine, we accept that who's sitting up eating. Is that as accurate as if we were to do it correctly, which is they're moving, right? What if they had a cigarette 15 minutes ago and you're working at the doctor's office? As cuff, how do we determine if it's the proper size? Yeah, we're going to measure that cuff size there that's got those little lines, and the area should fall within the lines. Do we take the blood pressure with the arm side? How do we do these things? Should be about level with the heart, right? Do I want them to have to hold their arm up? No, using these muscles, and these muscles are squeezing on the blood vessels, so is that going to alter the blood pressure? Sure. So there's a lot of things there. So please know we're not able to do it every single time. But if we're looking at someone for a cardiac assessment and they're for high blood pressure or low blood pressure, we need to make sure we're getting accurate measurements. And if you're sending in, because that's going to alter a lot of that patient's treatment regimen, we're going to base some of our medications, they're going to be slower. Do we want to give somebody Lasix at 9 p.m., which makes them, slows their heart rate down? So now when they stand up, they're dizzy, and they know they're going to be standing up in the middle of the night. It's really important that you do a good job making sure that you're getting an accurate assessment there. So please read over those boxes if you have questions. And they're also going to get a height and weight. What does that have to do with anything? Finally, 100% established that daily weights equals fluid volume. I am so happy to hear it. Thank you all. But yes, to check on their fluid volume status. And B, when we're comparing height and weight, what can we calculate? Right? Because didn't we just say that weight gain and obesity directly correlates to cardiovascular disease? Obviously, if someone's morbidly obese, we can see that with our eyes. We don't necessarily need to have included. I fall into that overweight category. We as a society have kind of become accustomed, most of us are, right? That's the average size between a 10 and a 14 now. So that's our average size, but is that considered a healthy, considered overweight? And so just because we've accepted something as normal in our society or in our best health practice, if we actually measure that height and weight, calculate that, be them on the right track. Does that make good sense? All right, so we've talked about these. I'm going to recap. Inspect hair, skin, nails. We didn't talk about hair, skin, nails that much. What is the impact of the nails will club? What about our hair? It's going to be what? Thin, dry, brittle. Why? How? 90 days. What about skin cells? Every day to have a sufficient blood supply to be able to proliferate as rapidly, get those nutrients through that process of osmosis and diffusion, so take the nutrients that it needs to grow, right? So hair follicles absorb the nutrients that they need to grow. No. So I hadn't really touched on that, and I apologize for that. They do change so rapidly that the poor blood supply to them is going to decrease their how well that growth occurs. And you're not going to be able to always, you're not always going to be able to assess it. Legs, maybe the eyebrows, maybe the arms, because right now, if someone doesn't have adequate blood supply and we look at their legs, do most of our mature patients have a decent amount of hair on them? If you look at your cardiac patients, most of them really don't have very much hair on their legs because it gets those primary organs and those capillaries aren't working as well. So maybe look at some of the extremities first. Look at the overall picture, absolutely, because that's always going to be our first is the changes. You might not see it, but they might say, my hair has gotten brushed their hair and it looks like they just took a squirrel out, right? Like they brushed their hair and all this hair falls out. These people may say my hair is just getting so thin or my hair's falling out. And that is a little bit as the nurse between admission and discharge, but the patient may report some of those sign selection, asking those questions about, have you noticed any changes in your skin? Is it going to be more dry? Good. No. Is our elasticity going to be as good? No. And some of those are age-related changes. Evaluate that in the whole picture. We talked about JVD, we talked about cap refill. We've already done the little picture. You can see through if the little diamond disappears, that's because the nails are clubbed. They've got that little bulge there, so that diamond, a lot of times you can see it, like you walk in and their fingers like a big round ball, okay. But sometimes if you can't really tell, that's going to be indicative of what? Hypoxia. But we're talking, you're correct. How does clubbing, or what is causing clubbing related to the heart there? So that could be from the fact that maybe the heart is not pumping as efficiently, excreted. There's a couple of different things here that can cause that. So familiarize yourself with what you see that could be creating this more than once in my story now. So palpation. So we've talked a lot about look, right? So everybody lay your hand on your chest, basically below. Y'all are going high and I'm going low. Basically go. Can anybody feel their heart? Be still, be quiet. Now lean forward. How many of you can feel your heart now that couldn't feel it before? I'm a special, everybody. She can feel her heart all the time. The PMI, the point of maximum impulse, that's going to be the strongest point. So that's where you may be able to palpate and actually feel that. Remember, we have to be able to feel it as well. If your partner sitting beside you is fine with you, you can turn to each other and assess that. Please don't turn to each other if you're comfortable with that. Feel under the chest right here at the base of the heart. I think it's at the bottom, right? So it sounds a little backwards, but the apex is down here. So feel of that. When I lean forward, what happens to my inside? They fall to the front a little bit, right? So maybe I can't feel it now, but if I have that pain, the heart is going to kind of move a little closer and make it a little bit easier to feel. So tonight, Go Homes is really good on because you can feel their heartbeat so strong because they're so thin and it's right there. And you will feel a significant difference in the strength of their heartbeat one side to the other. So make sure you go home and do that a little bit spot, and that way you can feel that coming from your patient. So temperature, but that is when the temperature of the skin or the area is going to be the flow is altered. Edema, we talked about this. Apply pressure over the boning area of edema. 5 seconds, they reckon it's in 1 or 2 seconds because our patients are swollen. Yeah, so it doesn't necessarily have to be over a 5-second period. It squishes down and you feel all of a sudden it went from squishy to hard because you touched the bone. You can let off and then feel. So if it does dent in and when you take your finger out, you still see your finger there, what is that called? If you push and you can squish all the way down till you feel bone and it gets hard, then you lift your hand up and it disappears, but you know it's squished from still edema. The area is still swollen. It just doesn't stay separated. It's a picture of edema, pitting edema there. You don't have to really squish that to see it, right? We're at measurement. We need to press that indentation so we can measure that +1, +2, +3. All right, so we've talked a little bit of S1 and S2, and then S3 and S4, those extra sounds, those are abnormal. S3, this was S4. We just need to know that it's extra and it shouldn't be there, all right? Murmur, what is a murmur? You know this answer, you just haven't associated the word exactly right. So that noise that you hear as the blood's kind of moving through that valve that's a triangle, that's that murmur. We already talked a good bit about the pericardial friction rub. That's that serous fluid, that oil or lubricant that's missing or the heart is. So you heard me talk a little bit earlier about that PQRST thing, and we were saying feel, but since they've given you a little visual here, I'll just mention briefly that P is kind of the SA node, and then you've got that AV node all the way down to the end of the Purkinje fibers, and then that T is when the heart's resetting. So when you're hearing these sounds, that S1, that closing of those, remember we talked about bling and emptying and all those being similar words. So that's where you're going to kind of hear that is as this, we're not letting it backflow up there. As this squeezes, it should be going out here, but not this way. Squeezing down, those pieces are clasping together and you're hearing here. And then remember how I said it's resetting and filling back filling and getting ready to send away. And so that S1, S2 is all we should hear. If we hear those X or at inappropriate times or maybe not in conjunction with each other. So we do a lot of diagnostic tests for hearts, right? Arterial stiffness index. That's pretty basic. Arterial stiffness, what does that sound like? Is the artery so stiff that it's not really allowing the blood to flow? Brachial artery, where in the world is a brachial artery? See, look at y'all remembering your A&P stuff. We're measuring the waveforms coming out of there. Have any of us ever performed this test? No, this is not something. At Sanger Clinic? Yes. You're going to see this commonly done in the cardiologist. This is more for that prophylactic care or that preventative care than that treatment in response to an X-ray. Why would we do a chest X-ray? To see the size of the physical side. Absolutely. CT, what does a CT do? Vessels, absolutely. CT. So we can see, does someone have, what's that word again for plaque vessels? Looking at that arteriosclerosis and the atherosclerosis and seeing the flexibility as the blood's moving out of there. And then MRI and MRA, what's the difference in the I and the A? Angio is actually looking strictly at the vessels through the vessels. So a lot of times you're going to have dying. The thing that's neat about the MRI, so we can look at the picture from like any angle and it moves like this and like this and like this and like this. And it takes a 360-degree picture and there so that you can look at it as a 3D image. So we can see the whole heart because it's taking pictures all the which part's moving, which part's not, what's going effectively, because we talked about it doesn't work as well, right? Well, when we look at this MRI, it will actually give us a visual piece at the bottom of the ventricle. It doesn't really move. It just kind of flaccid. While everything else is pumping, this piece just does like this. And so we can, and it gives it to us in that 3D imagery. ECG, EKG, you've heard it different ways. What is that? Yes. So there's two specialties in cardiology. There's one who's special, and then you have this electrophysiologists who are specialized in the electrical conduction of the heart. But electrophysiologists don't just understand the function of the heart, they understand every component of it as well. But it can be recorded in a couple of different ways. Typically, you have 3 or 5 leads. It's going to be 1, 2, 3 in the middle, 4, 5. And that's kind of giving us 5 different views of the heart. And then if we need assistance, a lot of times we'll advance to that 12 lead. I've personally never actually in the hospital setting, you're going to see 5 or 12. In a long-term care setting, if you have an emergency equipment, you're going to have enough. A lot of times in the OR, after a minor procedure, when they've been well, a whole bunch of stickers aren't necessary, we'll do 3. So 3, 5, and 12 are going to be your most common. 15 and 18 are options. Not necessary. Signal, average, ECG. What in the world is that? So you're averaging the functional signals of the heart over a period. People or patients that have something wrong with the ventricle, that AV node is maybe malfunctioning, those ventricular. And so we're looking to see why. Is it beating too often? Is it sending out a signal like it's supposed to? It's sending one out every half second. So now we've got a heart rate of 120. What's occurring? Respiratory ECG monitoring. That's exactly what it sounds like. Walking with it, right? It's mobile. You can take it with, or an external monitor that you can take. You wear it. You do your normal gym, whatever you would normally do. You wear this for 24 hours, sometimes more depending on the need. And you're going down the street and all of a sudden you feel dizzy. You need to write down, I was walking down the street, had been walking for 20 minutes. And when you go to the doctor, they're going to look at what the muscles were doing and what the electrical conduction, and see if they can't figure out why you're feeling what you feel, A, and B, something that's consistent, pretty easy to manage, right? But if your heart only does something every day, what are the odds of it happening to occur while you're sitting in the doctor's office telling you? I promise you, if you set 24 hours and it does it every 24 hours, it would do it the 124 hours you sit in the doctor's office to see what occurs so that they can still figure out and treat you, but you don't necessarily have to stay in a hospitalized setting for it. All right. The ultrasound of the heart, that's going to look at the heart's movement, the structures of the heart, the size. It's going to look at the movement of the valve. It should, or is it backing up and regurgitating into an abnormal space? Is it fluxing back up where it shouldn't be? Stress the heart, right? We may have a walk on a treadmill, or we may give a patient some medication to stress out the circumstances. If you're preparing a patient for one of these events, tell me some things you feel like your patient might, how they're going to feel, maybe that they're going to be lightheaded. So I'm coming in for this stress echo. See if they can even exercise. All right, well, you determine I can walk on a treadmill. I'm not dressed properly. What do I need? I need probably some tennis shoes, something like that with big old metal underwires. No, probably not, because we're putting all these stickers under my chest, right? Do we want some kind of sports bra? Do we need to go smoke before we come? Do we need to have run the night things? If you were to educate your patient, how would you educate them properly on preparation? Want to drink coffee? What about water? Sure, we need some water, right? We need to be hydrated because muscles got to be dehydrated. No, so we need to have that water on board, but we might not need to drink coffee and soda and tea, right, to stress it out some more. So make sure that you're prepared to talk to your patient about those things. Transesophageal acronym we use for that. TEE. All right, what does that mean? Transesophageal. Huh? Yeah, and to actually put our visualizer, our camera, if you will, inside the esophagus, right? Because I got to look through the outside, right? What do I have to look through if I'm going through the esophagus? The esophagus, basically, right? Just that better. So this is going to give us a much better picture. Is that as easy of a picture? Yeah, we don't really have to do anything for a regular ultrasound, right? Just kind of lay there and let them do it right before I stick something down their throat. No, we probably don't have a mess to clean up if we do that. So there's other components, recognize all the things that you need to educate your patient on prior to these procedures so that when you go in to work as nurses, so I think that's some important information. So we talked about this just briefly. We're going to get a little bit more detailed. Throat anesthesia. Numb the throat, absolutely. We're going to use some chloroseptic spray or something like that to try to reduce that gag reflex. We're going to play that last line, say. That's a pretty important, you could see something like that again. I feel like you might need to know that's then to numb your throat. And the procedure only takes 20 minutes, right? It's not a long time to do. A couple of hours. And you just told me that our patient was NPO to go down for the procedure, right? Because we don't want them to gag and throw up when we go to do the scan. Can I get something to drink? Can I get something to eat? Sure, here you go. Some pneumonia because you've let them inhale their soda, right? So it's important, maybe a little bit, but it is important because this directly impacts your patient's well-being. If you haven't thoroughly assessed that gag reflex first and you give them that and then they end up with aspiration pneumonia, that's on you drinking. Cotton swab, tongue depressor, whatever you need to do, something back towards the back of the throat, see if they actually flex. What do you think you ought to do before you send them down? Ask them or test and see if they got one. And then you test them for 7 hours and they never respond. They're going to get real hot. You would get an order from your physician. You would communicate with them, able to elicit a gag reflex prior to the procedure as well, and the physician will give you an order, and you're going to do something like water your problem, and you're going to have them take one small sip, see how they do, and then you can advance. You're not you're going to let them take one small sip of water, make sure they tolerate it, another, and if they do that, then you can exercise stress test. We talked a little bit. Peripheral vascular stress test. What is that? How do the peripheral veins or vessels be? Do the vessels respond? Do they constrict and dilate appropriately? Do the valves respond appropriately? We don't need a test because we're not doing this. That's all on that. Tilt table test. What in the world is that? On this table, and the table will move, and it's going to alter the way the blood flows, and we're going to be able to see what the response is. Hopefully, we don't use in heart rate, changes in blood pressure, things like that we can evaluate. In essence, we're doing orthostatics, but we're doing it on a special table. Doppler ultrasound. What does that do? Feet, yes, feet, wrists, whatever, where you can hear the sound. So through like this, or is it going? Yeah, it's kind of that zigzaggy, right? Because there's a heart pump. Listen with our ears, though we can't just lay our feet. I feel like Scuttle and Little Mermaid listen to the bottom of his foot for a heart. Hear that blood flow moving through there. But you can use a Doppler, which actually measures the sound weight and a little bit of an undulation as if the heart was pushing it through. You should be able to hear through that. And that's indicating that there's not blood flow through that area. Some of you have seen that in wound care, about using that in wound care, because that helps to make determinations between venous ulcers and arterial ulcers. Going to heal if there's arterial insufficiency. Pretty slow because they're not getting what they need. So they're going to use that quite a bit there. I'm going to pay attention to be safe. Identify patients, name and date of birth. Make sure you know what your identifier is. Get important test results to the right person, and we do that right away. So any of these tests, static, vital sign, that's something we can actually do on the floor of the hospital, right? What if we systolic when they were laying down to 94 systolic upon standing? But we need to report that information. Do we want to wait till the end of our shift and hand off? No, you want to, or the physician or NP, whoever is aware that that result is there. Because if that patient ends up having a fall later in the day, they got dizzy when they stood up and you didn't tell nobody. Who's it on now? You. So make sure you have the heart when the potassium and sodium is out of balance, right? You get a critical call that says the patient's potassium, they have a heart attack later. Who's in trouble? You, because you knew that they didn't have anybody to fix it. That's on you. So please make sure that you're reporting your information to fix it. 5-minute break for everybody. I need a 5-minute break. All right. So cardiac biomarkers. Cardiac bio, you're going to hear, particularly in the hospital, you're going to hear enzymes. You're going to hear like cardiac. Very rarely will you hear somebody use the word biomarkers, but we're going to talk about what each of these are. So first, we until this moment, and nor will we say it again, CK. That's what it is. How many of you have had labs that I asked you about and it said CK? Some of y'all looking at me like you don't know it, and I even made you teach about it in that little room on 3rd floor. But okay, no, but really CK and CKMB is a more specific component of that, the troponin and myoglobin. Muscle in general, that looks at damage to him. Look, now it registers. That's an indication of muscular damage. CKMB, if it has M, of cardiac muscle damage. Okay. Now, the thing about a CK is that it's going after the event occurs, and it's going to reach its maximum level of elevation about 12 to 18 hours after. Then we have myoglobin. I know I'm getting out of order, but I'm doing it on purpose. So just one to show an elevation. So like an hour after the event occurs, you're going to see it all on the floor, running full speed ahead, and hurt my arm and my leg and everything else. Or I have increased in an hour for both of them. It's not specific, but it's fast. So we do want to gives us that initial, oh gosh, this just happened, where that CK are going to take 4, 5, or 6 hours to show up. That's going to give us an indicator right away, on in 4 to 12 hours. So where that CK or that troponin is just now really getting elevated, that troponin begins 4 to 6 hours after the event and peaks 10 to 24 hours specific to the heart. Troponin is only going to elevate with that heart injury. Other muscle injury, it's going to be more with the heart, but it's going to elevate with other injuries, but the troponin will not. So 2 weeks ago, rhabdomyolysis CK was like 3,000. It was one of y'all. I mean, I didn't just make it up. It was you. Rhabdomyolysis. RHA. Y'all know I can't spell. All this is going to frustrate me now because I remember it because we talked about it. Or to help clear out their kidneys. I don't know. Whatever. It don't matter now. Moving on. Sorry. say Allie, oh, Andrea's gonna love this. Allie's been out at the bar and she passes out on, she's like all wedged up between the toilet and the sink, the vanity, right? The sink or the stallage. All right. So she falls over and she's wedged between there. What's happening to those muscles? They're being stressed, they're being squeezed. What's her body doing right now? If it's dehydrated, because is she in a very comfortable position? Probably not. So are those muscles being, so what's happening to those muscles? They're being damaged, right? They're dehydrated, they're stretched out, we're gonna see an elevation in her CK, right? But her heart's perfectly functional. So are we gonna, if we don't test it, will we know that it's not the heart? No. So why do we do them all this together? And then we also want to look at the myoglobin because it's going to tell us as soon as the troponin as well are going to take a little longer. But if we see that myoglobin and she says, and we see that rise in an hour, then we can go ahead and start treating Allie right away, where if we just a little bit different outcome. Does that make sense? Now, I said the word serial. What does the serial mean? Continuous, repetitive. So serial enzymes. Do we do these labs once? No. How often and how many? It's going to be a minimum of 3 times. And then we're going to look at them every 6 to 8 hours. Because we want to see that trend because we're looking at that peak. We know the onset, we know that peak, 10 to 12 for that troponin, 12 to 18 in that CKMB. So if we continuing to go up, what's that mean? Damage is still occurring, right? But if we see that back down, the damage occurred, whatever caused the damage is cleared and it is passed. But that's giving us an indication that damage is still occurring, something's still long-term major complications. Does that make sense? So anytime we do these cardio biomarkers are a minimum of 3 times, and it's going to be 6 to 8 hours apart. You may have a physician stop, right? Because every one of them should have shown an elevation by 12 hours. So if none of them not it, don't waste the money. But unless someone gives you that order to stop that, you're going to do it all 3 times, 6 to 8 hours apart. What is this? Okay. So we're looking at what's on the inside of a blood vessel or inside of the heart that prevents endocardium, endothelium, right? Depending on where we're looking at. So that homocysteine is doing the same thing levels. That's going to give us an indication that that endothelium has been damaged. And since we've got that ice skating rink, right? What happens when an ice skater's on there? They make them little tracks, right? What happens when a hockey player gets out? Homocysteine's that hockey player. You're going to see that rise because they just shredded the inside of that nice smooth rink. They made it smooth. Now they can clot. It was smooth before. Now it can't be as smooth because we're at high risk for developing clot formation, things like that. So now we've got this little clot, right, system. It breaks off and it flies through that vein. It comes back and it goes in the heart and it's tapping. I got to pee. I can't breathe anywhere past that, or I don't have oxygenation. So my lungs, maybe it was already over here, and so it developed inside the lungs. So it came out, went to expelled it. Where did it go now? To my aorta. So it's going out of my aorta and it's going to go upper extreme, right? So what if it goes into my brain? What's that called? A stroke. So now I've just thrown a P or a stroke. What's that cause? A heart attack, an MI, myocardial infarction, and that's in those blood vessels. And so cysteine levels aren't necessarily directly correlated to the muscle injury, but they're telling us about an injury. Clotting and making us at predisposed risk for stroke, heart attack, PE. And all 3 of those are important there. Lipids. We talked about this. We know what lipids are. Fat deposits, right? Good fats. We have bad fats. Sometimes they work in conjunction with each other to help eliminate the bad fats in our system, and they build up. One, they narrow the vessel, which increases what? The resistance. The other thing is, though, what if that big old fat blob just breaks off one day? It travels. It does common occurrence, not nearly as much as those blood clots are, but that is something that can develop, and so we try to prevent stress, things like that. Now, we talked about the coronary arteries a little bit ago and how those blood vessels supply the heart on the way back to the beginning. There we go. So these little red lines here and these little blue lines here coming off the front of what I'm talking about here. These red and these blue right here. These are the coronary arteries and veins. These are artery vessels. Look at the size of the coronary vessels. They're much smaller, right? So even something in these coronary vessels. And if we cut off blood supply here to the heart, what's happened? Ischemic supply has been cut off. And so when that happens, it can be for a couple of reasons. Maybe we had an embolism. The person's had those high cholesterol, those high triglycerides, and that that build up in that area. And as that occurs, we have reduced blood flow here. So it's the heart muscle getting all of it needs. As that occurs, that build up over time will eventually cut off the blood supply to the heart muscle, which is the reason it's so important to monitor those triglyceride levels, monitor those cholesterol levels and lipid levels to make sure we can supply the heart with what it needs. Let me scroll way back down here to where we were and get through this last little bit. No. I mean, which one's good and which one's bad? Okay, low is negative, high is good, right? That's kind of a basic thing. The normal ranges for that. You should know that from your lab things that you've been doing every day. Every time you've had that cholesterol, we know we're looking at that 100 or 150 mark there. So take that as likelihood for coronary artery disease and give you 4 cholesterol levels. All right, so that being said, cardiac, this vessel, and we're talking about the fact these coronary arteries that are supplying blood to the heart, myocardium, and that's what's beaten to allow this blood flow through. So when we talk about somebody going down now, where? In there, are they whole heart like the ventricles, or are they looking at the vessel supplying the heart? The vessel supplying the heart that goes in through those arteries and goes up into this area, and they inject a dye, an x-ray machine, right? They watch that dye. Now, if we see something and the blood's moving through this vessel, sudden, the dye streak, which is black compared to everything around it, gets as thin as my cream, narrowing that artery. Maybe it's that cholesterol and triglycerides. Maybe it's that plaque that just gotten a stricture in it or narrowed. So this is where we do things like stents. This is where we do things to help. Cardiac cath, we're not going to discuss any more than what we just did. We're going to talk about heart cath. That's really those cardiac vessels and those cardiac veins and arteries, and we're going to learn about each one. And we are going to talk briefly about these because they're important procedures. Now, that being said, maybe what do we understand right now? How to care for them before and after, right? Because we might not be involved enough after. So what did I say they poke a hole in to do this test? An artery. Thick. So is it going to take a little more time or less time to clot? A little more. Is it more likely to bust open? Yes. So what do we have to do to prevent that? Upwards or going to be 5 or more. Absolutely. We're going to do that more in that hours time frame where a vein may take that minute. Sure. Maybe I had it here in my arm, right? So we use like the radial artery or something and all, right? So the blood is coming out of my heart, going down, and you've applied a pressure stopping. What about these things? I got to do what? Refill. Temperature, oxygen saturation, send that Doppler. Because is this the only artery I have in my arm? No, I got others, right? So that's nice and supplied. But if I go in for a heart cath and they tell me didn't pay attention, we got a problem, right? So please make sure that you're aware of how to do assessments you can use. Radial, brachial, femoral. If I use the femoral artery, what would I be assessing? Below that, temperature, color, pedal pulses, all of those things. So make sure that you're prepared to pre-op and post-operative care of that patient. Because we are doing that procedure, but we understand how to care for the person undergoing procedure, right? All right. So I'm going over this again. Exercise, smoking cessation, healthy diet, weight management, all of those good things. Is it easy to quit smoking or lose, or we're accountable to? Yes. You know you ain't going to get up and go to the gym at 4:30 in the morning by yourself. But when you don't show up the rest of the day, they're going to call you out on it. You're probably going to get up and show up just because you don't want to get up light. So we can have this patient's experience and weight loss, smoking cessation, and they're going to be supported by the has to say about her. So she ain't showing up to the gym with the rest of it, but that's on her. Well, wait, what time you? Yeah, you. 5 o'clock. All right, so you're leaving the house at 6:30, but you don't leave till 6:30. An hour and a half before you leave. What you doing? Good Lord. But anyways. He's got. Oh, so you're gonna stay in the shower for 30 minutes? All right. Some of these people, they got to get up at 4:30 if they want to exercise if they're gonna leave the house. 4:30. All right. But now he tells us we've encouraged our patient to get up and exercise. We've utilized support groups. Other things that we can do to help them right now. Anti-embolism. Who's had to put on some TED hose? Let me tell you, by the time you don't need no more, right? So anti-embolism stockings, TED hoses you refer to them, those are compression devices. They are literally stockings to apply pressure. Typically, TED hoses are going to apply about 30 millimeters of mercury, improve that blood return, that venous return to the heart, reducing the risk of clot development. Some of you have heard them called SCD, sequential compression device. It compresses. Just like those, it's applying pressure to those veins into the inferior vena cava, moving it up into the heart just like it should so that it can be circulated back around. The red blood cells are carrying the hemoglobin. Well, now my heart's floppy and it's short of breath. I'm probably going to have cool fingers, things like that, maybe low O2 sat. But if I hyperoxygenate mildly, then the heart dies, the muscle dies if the blood supply cuts off. Is it because of oxygen? So if we can give a little bit of that extra oxygen, what little bit gets through there will oxygen for cardiac. Medications, antihypertensives, exactly what it says. Keep all the rhythm of the heart. Anti-anginals, what in the world is that? That's going to be like a nitro. Do and don't like that answer, and I'll say why in just a minute. It's to reduce the pain in the chest. Thing on the list here. The reason it reduces the chest pain is because as the blood vessel dilates, the muscle, which is what's actually causing the pain. So yeah. Anticoagulants, that's reducing those clots. Cardiac glycosides. What in the world is that? Okay. Is glycoside the same thing as glucose? More appropriately fit with. It's not necessarily going to be with the conduction there, but we're talking more about those linings, that glycogen, those peptides that are on the inside there. Thrombolytics, and one of them is breaking up. Thrombolytic is more breaking up the clot, where the anticoagulant is preventing the clot, and then the vasodilator is increasing the air. And you can see where some of those fit into this list and some of them that don't. The hypertension chapter about some of these meds. So we're not going to have a major conversation right now. Until we talk about rhythm in 103. The vasodilators I will speak on right now just a little bit. But that vasodilator, that's actually making the blood vessel larger. So when it to the area, right? What can it also do though? Increase or decrease? Exactly. The vessel is getting larger, so the resistance is in a larger space, so there's less pressure. So your blood pressure actually drops. So vasodilators do things that maybe it couldn't fit in before because of atherosclerosis or arteriosclerosis. Now that vessel is like hypotension, especially that orthostatic hypotension. So it administration to make sure that we know what to watch for. Because yeah, I'm giving that vasodilator to reduce chest pumping, blood pressure, or maybe a headache, because all of a sudden these blood vessels, and maybe I get this headache from it. So we'll talk a little bit more in detail about some of those things going forward. Cardiac, to prepare a patient for cardiac surgery, that's not something many of us are going to do in the next year. Our clinicals are. But if we're doing cardiac surgery on someone, you're going to have something called a stirrup. And when they attach it back, it looks really pretty cool on an x-ray when you see it, because you can see these twist it 2 or 3 times to keep it in and cut it off. So when you see that on the x-ray, you can see the wire where and when they're put onto bypass, because do you really think that you could see to do what you need in space? A, you can't see. B, where's their blood going? Goes into the filter or out. We do something called putting them on bypass. And what that means is the blood bypasses the heart and lungs and is put back. And so they make these things called anastomosis. So right here, remember we talked about an anastomosis little place and put a catheter in the aorta, and then they've taken it away from the vena cava. So the blood comes out, goes into the through and oxygenated, and it goes through this little roller system. Why the little roller system? Out. So the flow, it keeps it flowing in what kind of system? Yeah, so like if I'm doing something and my heart's beating, what does my blood look like? Motion. So now if I have something in this circle, if I wrap a tube around the circle, squishes it out and fills it up, right? So that circulatory system mimics beat relaxed. So the reason it goes through these rollers is because as the rollers come in, it fills up, and then as they roll through, it swishes it out. So this mimics flow as if it was coming apart from the inferior and superior vena cava into a machine that exchanges or cools depending on what they need, and then it is sent through the roller system and back in through the air or anything that's in the way, like a clot. Because on the outside, once our body is exposed to air, before we send somebody in for the surgery, what do you feel like we would need to administer? Heparin anticoagulation. We hold that, but on this one, it's a little bit different. So make sure you're aware of what you need to evaluate it and then consult and verify with that physician. But some meds we need to stop a couple of hours before, a couple of days before, like their warfarin, their aspirin, any of those platelet aggregates. So that's kind of the only, since we're not going to have the opportunity to do that in our careers right now. Yes, sir. This is the lung. Yeah, so ask me again. I don't know, like. Correct. The bypass when the surgery is done. Well, it's still connecting to the aorta, and that's sending supplied blood to keep them alive, but the oxygen exchange is not occurring. And then when you reconnect, disconnect here and close that up and reconnect here, the lung, like you pushed pause on your VCR during bypass. Yeah, I'm that VCR. What you talking about? I don't own a DVD player, but I own a VCR. I don't need my VCR now, though, since Disney came out. Because, see, that was the deal. I had all my tapes all over again just because they came on DVD. So I just bought a VCR because it was way cheaper than buying 3 DVDs from my old videotapes. But now that there's a Disney channel, I don't really need that. And I don't like clutter. Disney Plus. If you don't want, okay, I'll relocate. Yes, sir. Atelectasis. Yes, it can. But when someone has a major surgery like this, what kind? Oh, really? Just a nasal cannula? You think that's going to sustain them? What do you think? This person's going to have an ET tube, a breathing tube, and they're going to receive mechanical ventilation. Those ventilator settings are going to force is a possibility, but so is pneumonia and everything else, because anytime we have a major decreased movement of those alveoli. So yes, you're 100% on track thinking about it. When this surgery is over, this person's going to be on sedatives, and they are not going to have, they're going to continue to receive support through that machine ventilator, providing them oxygen, or just to allow air in, things like that. And we're going to have a respiratory therapist come and talk. He will give you a lot more detail about that ventilator support and stuff, but we can actually set it so that when it is pulling the air in, the air is pushed in through that tube from the machine, which reduces that atelectasis, called continuous positive airway pressure or positive airway pressure. It's pressurized airways to reduce that atelectasis. What bypass machines look like and some of the equipment that's required. Please understand why anybody who has open heart surgery has super special stuff. He's Dr. Bridges. Bridges, is that his name? He's my height. And he wears with them brown circles on the sleeves, you know what I'm talking about, like from the 80s or them things with the reinforced sleeves. Okay. And I don't know how old the man is, but he's 100% like Doogie Howser. I think he graduated from Harvard and also graduated from MIT. The same year he graduated from med school, he graduated from MIT with a master's in. And so he created the bloodless heart surgery. So he has created because you see here on these bypass machines, you can see where all that blood is outside of their body. Imagine what is. Those patients almost always have to receive a blood transfusion to be able to just maintain, because they almost like you kind of give them this in advance so they've got this extra volume while you're working. And then obviously so he actually created a system to eliminate that called the bloodless open heart surgery. And that was Dr. Bridges, and he did a cardiac name or CMC name at the time. He's an interesting guy, lots of cool things that he can teach. Anyways, look, let's breathe for a minute and